It's a pleasure to be with you. What a lovely city here in Stockholm. Thank you very much for warm welcome. So, a couple of concepts that I'd like to impart before we really get started. To the point of, now that we're going to be in a world that's mobile, now that we have data, what happens to it? Who's accountable for it? You see, in every other industry, when data happened, there was an expectation that somebody would be accountable for that data. If I was an engineer and I was building a skyscraper, there would be an expectation that I would incorporate into my plan, into my strategy, the tensile strength of steel, because that's known and that needs to be acted on in a way that's useful to that building sustaining itself. So, a concept of a place where the data goes and is held accountable was first written about in the medical literature as far back as 1968. It was referred to as the medical home. It was in pediatric literature, and it's a home for the data. You see, if you're sick enough and you're complicated enough, there's got to be some place where all the data exists and can be acted on and be held accountable. I think the first folks that really did this in any meaningful way in healthcare were the transplant surgeons. You know, if you have somebody sick enough that they need a new kidney, it became very clear to them very quickly that you can't have 5 people working on that person doing 5 different things and have the patient survive. So all the data's got to go to one place and be accountable. That's the system integrator. That's the medical home. So as a large buyer of care, IBM has about a $2.7 billion spend in America. Corporations buy care for their employees and families. We weren't happy with the care that we got. We had nobody in charge. We would have 5 partialists all functioning and interacting with our patients with no adult supervision at all, no system integrator, no coordination of care. It's dangerous, it's toxic. So we reached out to the House of Primary Care in the United States and we asked for a change of covenant. We said to them, how can we change the conversation around you delivering an episode of care and you beginning to manage a population in a healing relationship of trust? We asked them for a set of principles upon which to do this, and that became known as the joint principles of the Patient-Centered Medical Home. There was an article in last issue of Health Affairs that looked at Europe and looked at 5 European countries and said those that have adopted closest to that model have the best results, right? So we then asked our other corporate friends, we had 47 of the Fortune 100 in America join us to ask the healthcare plans to build this and deliver it, and we brought all the healthcare plans into the room in Washington, and we said to them as corporate buyers of care, if you don't agree to do these plans, none of us are going to buy from you next year. You're out of business. So we had a bunch of pilots that were kicked off. This was about 6 or 7 years ago. This is the data from those pilots. You begin to manage a population with simple aspirin, blood pressure, cholesterol. You begin to think about what's important in terms of management. You begin to see a drop in the need for hospitals. You begin to see a drop in the need for emergency rooms. You begin to see more medicine being taken for your chronic disease, and you begin to see better things happening. The Danish experience is interesting in that they've gone, I think, from about 150 hospitals down to about 22 in the last 15 to 20 years, and much of ambulatory sensitive conditions are now managed at home, they're managed remotely, they're managed digitally. So, of those early pilots, this is one of the results 6 years later. This is the state of Michigan. And we're getting to see consistent results from that data. The delta just keeps getting better again. So it's now become the standard of care in our Veterans Administration and the DoD. It's now rolling out, and it's the standard of care in Canada, and we're doing a lot of work in New Zealand, Australia, Singapore, etc. So when I was doing my training at Hopkins, we had this scratchy film of Osler talking about the fact that he was so privileged to be at a point of time in medicine that he was part of a transformation of the delivery system. We sit at that juncture here today. I mean, the most fundamental change that's ever happened in medicine is happening now. And there's three things that are driving that. The first is unsustainable cost. That's global. That's happening all over the world. The complexity of medicine has driven some of this. But if you look at this slide, this is the 15 years of life lived from age 40 on. So, how countries are doing in terms of value of cost of care per lives lived. The United States is dead last, and it's dead last at twice the price of any other developed economy. But if you look out further on that slide, you'll see Ogden, Utah. I happen to be on the faculty at the University of Utah. We have pretty robust primary care there. We have a system of managing a population, and we're much closer to you in Sweden and in Australia than we are the rest of the United States. So there's this huge disparity of care around the world. But unsustainable cost is one huge driver. The second driver that Peter talked about is data. For the first time, we really have data in healthcare. We've not had it before. I mean, data is going to do for the minds of our doctors and our patients what X-ray has done for their vision in the past 50 years. It's going to literally open up and become clear what's happening, right? You're going to be able to use that data to turn into actionable information at the point of care. The third thing that's driving this, and you heard about that from Alan, is mobile. You see, we have the first breakthrough in healthcare in terms of communication since the automobile. The automobile came along, and we could do house calls, and we could go 30 or 40 kilometers to do a house call visit, and then our patients got cars, and we stopped doing house call, and they could come to us. But no longer are we trapped in a world where it's the whites of the eyes that are the encounter that we're going to have between a healer and his patient, right? Think about that rural clinic in Rwanda that you just heard about, where you have a nurse that becomes a system integrator, where the data goes and is managed and handled at the point of care, and you have remote mobile tools that are powerful. I was in East Africa not too long ago, and I saw this device that was this big, hooked to a cell phone, and it could now read the genomic information and decide what variety of HIV infection the person had and indicate the treatment. That used to take us 6 months in 3 floors of a laboratory to do, and that's now available in a village hooked to a cell phone. It's fundamentally going to shift how care. My kids are 29 and 32. They've never seen a teller in a bank. They never will, right? Because they're already in a world that's mobile. So the world that I grew up in, the world that was being described by Osner, is called the Flexor model of care. It's where the doctor is a master builder. We pick bright students, we make them data storage repository units, and we put them at the bedside, and it's out of that data storage repository unit that the healing decisions are made today. That model's no longer going to exist because it's going to be changed, and it's going to look like this. It's going to be flatter. You know, that nurse in that small clinic in Rwanda is going to have the power of data, and it's going to be accessible to them the way a neurosurgeon would have at an academic environment in Sweden, right? It's going to fundamentally change how care is delivered. It has to. You see, no longer are we going to build cathedrals as master builders. No longer are we going to pull it out of our head. We're building skyscrapers. We're going to have to be accountable for the tensile strength of steel, right? We're going to have to know and act on the fact that our patients who we're trying to treat with their diabetes are not going to get better if we don't understand and treat their underlying depression, right? That sort of information is going to be acted on. So as we move into this world, care is going to be driven by data. No longer what's stored up here, but accessible data available to anybody. Every person's going to have a plan, right? So the medical students, as they go through school now and come out, they're going to be much more like engineers than they are master builders. It's going to be a team-based. It's going to be a team sport, right? You're going to have folks on the team that understand medication management, that understand behavioral sciences, that understand, but with data to act on, and we're going to be managing a population down to an individual person. Let me make it really simple. When I first moved to the Hudson Valley, in New York, I took my cat to the veterinarian, and my cat was notified because it had a registry that its immunizations were due. My wife wasn't, right? She wasn't notified that she needed her mammogram because nobody was managing her data. Nobody was acting on that. Nobody was accountable to that. So this is the covenant change we made between the providers of primary care, the healers, and the buyers. Our patients are the population. It's a community. We're going to react. We're going to handle that data whether they see us or not. We're going to notify and follow up and follow through. Care is going to be determined by a proactive plan. There are going to be standards about what we do. We're just not going to pull it out of our head anymore. We're going to be measured about our quality. We're going to have a team that does that. So we're really moving into a world where we're going to have superb access to care. Some of that access, much of that access will be asynchronous. It won't be face-to-face. We're going to demand patients are engaged, right? We're going to have information systems at least as good as my cat has. It's going to be team-based. It's going to be mobile. So this is a trajectory we did in the community where I live in the Hudson Valley. We started with providing $6 per member per month for our doctors to have registry, to have information. We began to train them on the model. We then took the care coordinators, the nurses, and put them right into the doctors' practices. We then began to measure the quality and value. We then reached a point where there was some accountability to the data, right? And that's known as accountable care. So if you're going to change the delivery system and ask the delivery system to manage a population, you're going to have to change the dials on how you pay them. No longer can you pay them for an episode of care if what you want to do is manage the population. And that's not rocket science either. That's a matter of having multiple dials, right? In 3 of the communities, we pay for service level. So how fast I answer the email, how effective I am in getting a patient in to see me, how well I follow up on my patients is a third of the income for the doctors in that community. That begins to fundamentally change how they respond to the patients, right? You know, so there's a process of payment reform that happens and is going on. And the third element of that is benefit redesign. How do you engage the patient to follow up and follow through, right? So we found that if we gave a patient their cell phone and we said, here, exercise and we'll cut your benefits in half, about a year later, we still had about 50% of our patients using that exercise device. But the psychology of how the human mind works, if we put a little reminder once a week, you're doing a good job, this is exciting, here's a team to play, a year later, 87% were still using that device, and we began to see significant improvement and decrease in the number of risk factors. So beginning to design the interface between how you engage the patient, how you pay the doctor, and how you change the delivery system now that we have data and now that we're going to be mobile. So we happen to be the largest employer in the state of Vermont, and we work closely there with the local delivery system, with the government. We began to put in place a community coordinator. So now at 11 communities in Vermont, Vermont is made up of 11 communities, we began to see our newly diagnosed diabetic having that community coordinator reach out to the diabetic hiking trail that exists on Tuesday, reach out to the grocery store, and there's the tour given by the nutritionist on Wednesday, reach out to the local pharmacist to have a conversation about medication management on Thursday, et cetera. So we began to take the resources of the community and integrate it right into what's going on. In Sweden, in one of the counties that I visited last year, you've taken the postal service worker and you've used them to stop at the house of the frail elderly and make sure that their toenails are cut and they're not tripping over a shag rug, and that the medicines that's supposed to be delivered are delivered, right? So that's sort of a thought process of supporting at the community level. So if any of you want a bit more information, Peter Anderson, by the way, a Swede, wrote a book about this whole experience called The Familiar Physician. It's now available on Amazon. I think you can get an electronic version for 99 cents for this meeting, and it's quite easy to read. And with that, I will end with 1 minute left. Thank you very much.
Thank you so much, Paul. Thank you.